recording right now. So now the presentation is being recorded. And so because of that, I have changed the settings to just disable video and mic for the audience to protect the quality of our presentation. But when we get to the Q&A, I will enable the mic feature so that those who do want to verbally ask your questions and discuss with the speaker can do that. And with that being said, I'm going to pass it to Dr. Beth Morocco, who is our Associate Director at the Injury Prevention Research Center. And she's going to talk to you all a little bit about our center and introduce today's speaker.
Thank you so much, Ciara, and welcome everyone. Thank you so much for being here, and happy Valentine's Day to everyone. We don't necessarily have a Valentine's Day theme for today, but it is great to see everyone. And just a few words about our center. The UNC Injury Prevention Research Center is one of 9 CDC-funded centers across the country. We're one of only 2 that have been continuously funded since the CDC started funding these types of academic research centers. So we're very proud of that. We've been continuously funded for over 35 years. We're multidisciplinary, which means we're not housed in any particular school here at UNC, but we span different disciplines and areas of focus because we know that injury and violence prevention is not relegated to a single approach or a single discipline. So in terms of our mission, we conduct injury and violence prevention research, but we also have outreach, training, education goals, and really seek to nurture and support the next generation of injury and violence prevention professionals. We also engage with practitioners and policymakers, particularly here at the state level. So you can see on this slide our focus areas, but we actually engage in all different types of injury and violence prevention activities in addition to our 5 focus areas. And with that, I just encourage you to engage with us. I'm glad that you're here for our webinar series. We have student interest groups. We have a lot going on. So I encourage you to go to our website and continue to engage with us. And thank you again for being here. So without further ado, I'm going to introduce our webinar speaker for today. We're very, very pleased to welcome Lauren Kestner. Lauren is the Associate Director of Harm Reduction at the Center for Prevention Services, which is in Charlotte, North Carolina. At this agency, she oversees the Queen City Harm Reduction and manages special projects that bridge harm reduction, prevention, public health, housing, and the arts to improve drug user health. As an artist by trade, Lauren got her BFA from the School of Visual Arts the BFA from the School of Visual Arts in New York City. She later became certified as a prevention specialist and joined the Center for Preventive Services in 2017 to offer youth evidence-based, resilience-focused workshops. And during this time, her passion for people and environmental health was the catalyst in developing the Harm Reduction Department, which to date has reached over 9,000 people who use drugs. Lauren's a fellow of the Georgetown and O'Neill Institute for Global Health's Addiction Policy Scholar Program, and she's dedicated to addressing the roots and conditions that perpetuate the drug war and is driven to forge sustainable long-term solutions that create equity throughout the continuum of care and socioeconomic support services. So very much focused on those social determinants of health, which is something those of us in public health can very much appreciate. So thank you, Lauren, very much for being here. We're really excited to hear what you have to say, and I'm going to turn the floor over to you.
Thank you. I hope I'm going to do this right. And everybody can see.
Oh, it looks great.
Okay. Yeah, I guess I'm just a little confused because now I can't see my notes, but this is all gonna be fine. I don't know why that happened though. So this is, as Beth mentioned, I'm Lauren Kestner. I'm with Center for Prevention Services, and I oversee Queen City Harm Reduction. I am a person with lived and living experience with drug use and justice involvement. And I am an artist by trade, and I don't really always understand how I ended up here, but I am here. And as a result, I actually haven't been able to create art in quite a long time, but people ask me all the time, and this is what I love to do. I love creating community. I love fostering networks. I love building communications across different spaces, and I find a lot of I feel very satiated in a lot of ways, and it's also very hard work. So I want to provide a disclaimer. This is a loaded presentation that I have to breeze through in about 20 minutes. I want to provide a trigger warning because it does go into some historical periods that are uncomfortable, and quite honestly, I'm not confident that I should be the one telling the story. There's just a lot of racial disparities, and for all of the things that I do relate to in the space that I work within, I am just driven to unpack this and continue to peel back the layers. I oversee Queen City Harm Reduction, which is a harm reduction program. We do syringe access, we do HIV, Hep C testing, among many other things. We have a priority to people who use drugs who are impacted by sex work, justice involvement, LGBTQIA community members, and people of color, and just really all walks of life for marginalized spaces. I do want to do a quick overview of history and the drug war, and from 2000, when things really, it was like 1999, but things really spiked. And over the course of 22 years, more than 36,000 North Carolinians have lost their lives to drug overdose. I don't go too much into the data here, but I do think it's important to note the substantial increase and the communities that it is impacting. And while I am going to be pretty focused on people who are Black in this particular presentation, I do want to make a special note of the American Indian rate. Tribal communities, certainly, I would love to unpack it all. So how did we get here? And the problem with the idea that history repeats itself is that when it isn't making us wiser, it's making us complacent. So brief history of homelessness. It is very difficult for me to talk about homelessness, to talk about this housing project for people who use drugs without talking about slavery and other critical periods that played a part in the development of very adverse conditions throughout society. I believe that understanding the nature from which the condition developed is how we will find sustainable solutions that value human life and support its well-being. But it's uncomfortable. We like to hit pause, we like to close our eyes, we like to turn away, and the only meaningful way that change will happen is when there's more value for very tangible human life, and that overrides the things that we remain very comfortable within, our homes and other securities that we value that I don't even think we realize often play a part in these larger issues. So a timeline for your consideration. Lincoln's.
Lauren,
Yes.
if you're switching slides, we can't see that. We're still on the main slide.
Oh, that's hilarious, but not. Hold on.
Okay.
That is really awkward. I'm just going to go ahead and unplug my monitor. I think that's what's causing all kinds of problems here.
Okay.
Okay, it was working before, so let's try to get it again. How about now?
All right, I see the title slide. All right, I see Queen City Harm Reduction. Yep.
Yeah, no, I just can't see my notes. Shoot. Give me 1 second. I am trying to do some very quick TA.
Okay.
Sorry, everybody. Thanks for being so patient.
Yeah, no worries.
So I imagine you can see this.
Mm-hmm.
It just takes away, I don't know what happened.
And if you want us to just do it in the view where you can see your notes, that's fine too.
Yeah, I mean, as long as you guys don't need anything super fancy.
Yeah, no.
Okay, that'll make it easy and we can keep it moving. Thanks, I appreciate that. So because we didn't see any of the other slides, here's where I mentioned the death rate over 22 years. Here's where I mentioned the substantial increase over the last 10 years. Here's where I mention the different marginalized communities that historically have been oppressed. And this is where I make note of our American Indian population. And today's presentation focuses primarily on Black communities, but I do want people to really take that one in. And how did we get here? And this is the quote about history repeating itself. Here's a brief history of homelessness that goes along with the other things that I was saying about how we can't really talk about one thing without talking about other. And here is a timeline for your consideration, getting us right back on track. And so Lincoln's Emancipation Proclamation on January 1st of 1863 declared that all person held as slaves shall be free. The 13th Amendment was developed at the end of the Civil War. The Senate passed it on 1864 and the House did not. By intervening due to the presidential election of 1864, Lincoln got the support that he needed, and Congress passed it on January 31st of 1865 and validated the abolition of it December 6, 1965. Even though it was abolished over the next 55 years, racial violence continued. This included lynching and massacres that targeted South Black people. The KKK was formed right at the Civil War's end, and the horrific violence and murder of people who are Black was the catalyst to the Great Migration that occurred from 1910 to 1970. When we look at the Great Migration, it was one of the largest movements of people who are Black in US history. Roughly 6 million people relocated. They fled to escape racial violence, to find safety, as well as economic, educational opportunities, and they mostly sought freedom from the oppression of Jim Crow. The first Great Migration, Black Southerners relocated to northern and Midwestern cities such as New York, Chicago, Detroit, and Pittsburgh. And when war efforts for World War I ramped up in 1917 and more men were sent, more industrial jobs were vacant, creating more opportunity for Black communities in non-agricultural industries. During this time, Black Americans also experienced the Red Summer. This was a pattern of white on Black violence that occurred in 1919. And I'm not going to read everything for you all, but this pattern sparked a reaction across other Southern locations and really specifically Chicago. And the hostility in the North had a lot to do with historical NIMBYism, if you will. And people who were seeking alternative territory were not welcomed because of the way they looked and the cultures and the diversity in which they came from. And at the time, it was not a lot of time since slavery had been abolished. The second phase of the Great Migration occurred after World War II. And with the expansion of the US military creating more jobs for people who are Black in new territories, this happened through the 1970s. People moved into California major cities, Portland and Oregon and Seattle, Washington. There was still a lot of housing discrimination, a lot of gerrymandering. Redlining became a thing. The historical NIMBYism that I mentioned before created policies that pushed people into silos within the communities that they fled to for safety. The tragic fact is that global slavery was not outlawed until 1981, which was the year before I was born, which is really not that long ago. And of note, all major cities identified above continue to experience a pretty substantial and really upsetting homelessness issue and drug use as well. Slavery lives on and is deeply rooted in white supremacist capitalism. And I use that language because, I do think that there is a balance, but when you look at white supremacy and capitalism, you find it in mass incarceration and forced labor, human trafficking, labor exploitation, sex trafficking among adults and children, and the drug war, which, I tackle every day, bundles all of it together. Most Americans play implicitly a part in this. We are complacent and we have those, unfortunate blinders and sometimes fortunate blinders. And a possible conclusion is that not everybody always knows that they can be a small part of really big change. And so going into the drug war, Nixon declares the drug war in 1971, and the tough on drugs and the tough on crime attitude was very heavily focused on Black people and their communities. We had learned from Haldeman that they were targeting people who were Black and their communities and the far left. You know, this was around Vietnam. And he says here, we knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and the Black with heroin, and then criminalizing both heavily, we could disrupt those communities. We could arrest their leaders, raid their homes, break up their meetings. Did we know we were lying? Of course we did. I think you can see this, but he emphasizes that you have to face the fact that the whole problem is really the Blacks. The key is to devise a system that recognizes this while not appearing to. So sneaky, but also very in your face. And you saw this in your media. Drugs aren't cool. Drugs drag you down. Reefer madness. Destroy the mad brute. Crack kills. I mean, it was just one campaign after the next, DARE being one of the worst. And Harry Anslinger is very famous. In this space, he launched the DEA, and over 30 years, you know, his racist ideology not only, you know, pervaded this federal entity, but a lot of different law enforcement departments and divisions across the country. And not even today, because people are like, I am going to be racist, right? Because this is just what we're indoctrinated with over decades and decades. I could talk about Harry Anslinger for a long time. And as a result of the DEA, as a result of this criminalization, this is where you see mass incarceration because of new laws and new policies that were designed to punish people of color and diverse cultures. And you can see here just how emphatic it really is, and tragic at the same time, because nothing happens beyond more lives lost to very preventable death and very, you know, practical solutions. And so a brief review: historical racial violence and oppression, housing, employment, and healthcare discrimination, violation of human rights, and laws and policy that today continue to allow this violation to continue. And so when all of these things happen to a person, you have to look at epigenetics. You have to look at intergenerational trauma. And trauma is encoded into our DNA. I have to find my arrow and move my notes down because that is getting really in my way here. But it's encoded into our DNA, and the complex trauma can result from a biological parent and what is experienced in real time by them after birth, and what you're experiencing in real time around that guardian. And many times over is where the complexity of it comes in. Interventions at various stages in life that promote resilience can tip the epigenetic scales, as they are reversible. So children and adults who do well in the face of serious hardship have a biological resistance to adversity and strong relationships with important adults in their community. If this resistance is not developed, many experience the adverse impacts and health outcomes that include mental health conditions, substance use disorders, obesity, among others. And this is more or less what it's like to be treated by the same people who oppress you. I mean, I think this meme is one of my favorites. And I also want to bring light to what people went through during the pandemic and just over the last year, and why you're seeing such substantial increases. You're seeing a disruption to public health care and data that I, again, you know, don't need to narrate, but I'll leave the slide up for a minute. And I'm going to skip this slide because unfortunately without the slideshow, I can't really show it, but I do show how people over the COVID-19 pandemic were released from the county jail here in Mecklenburg County. And a lot of that had to do with crowding and, you know, petty crimes that people should be released for. And so it was really great to see that drop. But then what you see in one of the slides that can't be viewed right now is that calls to the NC 211 they just skyrocket. way up. And you see unemployment also just skyrocket way up. And so when you have these conditions that are already stacking on odds that are placed against you when you're re-entering the community, not just from a jail, but from a hospital, from a treatment center, wherever you might be, it's very, very difficult to find healthy recovery. And we have very high rates of suicide and overdose. Most incarcerated people have a substance use disorder. And this was a wonderful study that was done by many colleagues that looked at formerly incarcerated North Carolinians. And they found that those who were justice involved were 8.3 times more likely to overdose in the first year after release, 40 times more likely to overdose in the first 2 weeks, and 74 times more likely on heroin. And then there's also a whole launch of that study that goes into what happens after a 2 to 3 year period. These are just data slides that capture the counties that do provide treatment to people who are incarcerated. I know that the territory might be difficult and I can't really show you, but Charlotte is kind of right in the middle there. I'm so sorry, guys, I don't have this on a regular slide viewer. And then here are the 8 counties that have a policy in place to remove barriers to hiring with people with a criminal record. I can tell you that right now, looking at the territory I'm in, they do not have this barrier removed. And so how do we relearn? The illiterate of the 21st century will not be those who cannot read and write, but those who cannot learn and relearn. How do we build resilience and the ability to overcome serious hardship? And going back to the slides, you know, when the odds are just completely stacked against you, how does homelessness occur? What triggers it? How do we build protective factors around it? You know, if people all have a biological and physiological characteristic that makes them vulnerable or resilient, we implement more resilient protective factors, more affordable living, more creative opportunities with landlords and folks that can essentially house people who need shelter. And in general, people are just seeking safety, just like they were hundreds and hundreds and hundreds of years ago. And so our program leans really, really heavily into Maslow's hierarchy here. I'm going to go ahead and just switch this. So, oh, nope, just kidding. Take that back. I thought that might bring me to the slide so I could see the full thing. So we lean very heavily into this. We want to meet people's physiological needs because we understand, and I can say from experience, I was never leaving a treatment institution or a jail and feeling like I belonged to my community. I didn't have a job, in all these things. And so when people expected me to get to this resource or that resource, and I had no car and no food and no phone, I mean, none of it made sense. But yet we have these very high expectations of what people need to do to recover, but we don't meet them on a physiological level to give them food, clothing, and just overall support that's going to meet these very critical basic needs. And that's where harm reduction comes in. You know, we are a set of practical principles that promote health and wellness. We run on a spectrum of strategies that encompass safer use, medicated assisted treatment, abstinence. We meet others where they are, and we offer needs-based care as well as evidence-based care, which includes HIV testing, HCV testing, naloxone distribution, among many other things. It's founded on dignity and respect and compassion for all life, and overall embraces humanity, prevents the spread of infectious disease, and has a primary focus on priority populations. And we don't look at recovery as a one-fits-all size, or I'm not saying that right, but I think you guys get what I'm putting down. We work on a continuum of access, so people can go up and people can come down and people can stay where they are. And if they go down, you know, and they move towards abstinence, but, you know, they take a few steps back, we're still going to walk alongside of them. None of that is going to change. And SSPs do a ton of stuff. And we are very good at attracting people who are justice involved. People are historically marginalized. We are heavily trafficked pathways to care. So why don't we include housing in all of this? Why are we not finding more alternative solutions? Because we do understand that substance use is a symptom of these much bigger conditions. We find in our annual syringe service reports that people need housing. 472 people self-reported that they do. The social determinants are there. I can share all of these resources. I just want to, breeze through some of these slides to show you why I got to the place I did in launching this project. This is a very preliminary snapshot of Queen City harm reduction and what we do. And more importantly, this was how we started to identify where we were going to target our Housing First project. Over the course of last year, we enrolled over 500 members. 24 reported that they were at risk of homelessness. 256 reported that they had vehicular residency, lived on a street or a place just not intended to live. 4 people resided in an emergency shelter. 14 were homeowners, et cetera, et cetera. And so here we go. We lean back into Maslow's hierarchy. How do we meet their needs? Here's the definition of homelessness, which I do not have time to read, but if you are interested, I will share these slides with Sierra. Here are the barriers and other stressors that prevent many people who use drugs from accessing housing. Housing orgs and group homes have abstinence requirements, and many still do not permit MOUD. Criminal records, stigma, years of abstinence-based models don't allow other evidence-based models in because, that's just a culture shift. If somebody is quote unquote sober and somebody who's on MOUD or somebody who's still using, even if it's moderate, a lot of triggers, a lot of things to consider. New legislation and intersecting legislation. So there's a lot of things that really factor into this giant issue. Our project-specific aims was to provide direct services to people who use drugs through voucher assistance. I spelt it wrong, but we embedded a critical time intervention for rapid rehousing model into the SSP. We are researching that model while we are also providing the supplemental assistance. And we are utilizing the SSP because it's a very low barrier way to reach the people most in need who cannot access Section 8 and other affordable living because of the barriers I mentioned before. This is an overview on critical time intervention. It's time limited. It goes for 6 to 9 months, but we are building in contingency management. It's meant to, in phases 2, 3, really place onus onto the individual receiving supplements and allowing them to really fly with a supportive network, of course. And it's highly focused. We really work on a very strict timeline, but at the same time, as harm reductionists, work to provide that contingency management that I mentioned. Phase 1, phase 2, phase 3, this just goes through how people transition in, try it out, and transfer. The case manager goes through this process with those who are eligible, which most people are, and they do fiscal management and budgeting. We do rental deposits, food deposits, transport. We pay for appliances. We meet the needs for utility bills. We have created some very hardy buckets in our grant funds to do just this. Here's some demos regarding our membership. This is a catchment of 30 people right now. Again, this is a pilot, so this is in very preliminary stages. And here are additional program member demos. We get a lot of data, but here were some that I felt were important along with the previous slide. HIV status, Hep C status, children, marital and sexual orientation. Here is some of the marks that we've hit so far. So we've got 3 people in, we've got a lot of people in pre-CTI. Phase 1, we have 2, I think 3 people now. Phase 3 is 3 people now, and phase 2 is 2 people, which is great. And I can unpack that a little bit if folks have questions. We ask questions around their education. As you can see, most people, well, that was confusing for a second. Don't look at the PhD one. We probably need to do better with our colors, but started but did not finish community college or college degree program, and 34.3% did not finish high school. Employment status, most people are unemployed. Some people have full-time jobs and some people have part-time jobs. And since we've launched this, there's been 0 overdose reports from those enrolled who have experienced previous overdose events. We had 1 hospitalization and 1 illness, but no job loss and no interaction with Child Protective Services. Here's the bulk that has not secured housing, but there is the catchment that has. And that is because of credit scores, their criminal background. These are reasons why people decided not to support a person in the application process, and they did not receive housing. And oftentimes they're not given a reason, but they're low numbers. This is, again, very preliminary. So here are overall data developments. Current living situations I went through already. Now we have 12 people housed and are in CTI phases 1 through 3, which is fabulous. We were able to support people getting full-time work, hour increases, and pay increases. A lot of people had pre-existing benefits, but many, more than half, received new enrollment. There are, a little over half that are justice involved, and 1 person has accrued new charges. Overdose events, those who had a history maxed at 14%, and no new overdose events occurred since enrolling into the housing program. And 40% reported pre-existing diagnoses and no changes in health status. Here are some other fun facts. I'm just going to leave this up for a hot minute. As you can see, there you can see the numbers. I was way off. 6 people are in phase 1, 3 people are in phase 2, and 2 people are in phase 3. You've got enrollment status, you've got health status, and you've got substance use. And we have seen a reduction in use, but it's really hard to solidify that data currently. And these are working examples. They do not involve CTI or critical time intervention, but this is Portland Hotel Society, which is in Vancouver, Canada. And this is a place out in the Midwest that does tiered recovery. So you can go into a respite home, you can go into triage, then you move into a recovery supportive housing unit, all the things. And that's it. That is it. So I hope that all came together in a very short amount of time, and I am so sorry, but thanks for letting me be really rogue here with you all today.
Yeah, thank you so much, Lauren. It did. That was a great presentation, and thanks for rolling with things. Technology never works when you need it to. So I know that we're a few minutes over, so thank you everybody for hanging on with us. And as I mentioned in the chat, we are still going to do Q&A for those who are able to hang on. And if you had questions but aren't able to hang on, feel free to drop those in the chat and I'll connect you with Lauren via email to follow up afterwards. And our next webinar is going to be on Wednesday, March 13th. And we will be having a presentation from Shay Robinson Mosley, who is a PhD candidate at Johns Hopkins University. And she's going to be sharing about some research that she's done related to mental health for student athletes and how team climate impacts athlete self-efficacy in seeking mental health care. So we hope to see you there. I'll have more information about that in my follow-up email. All right, so we do have a question in the chat, and we also have some praise to you, Lauren. Again, thank you for this wonderful presentation. So one question we have from David is, when advocating or requesting additional resources and funding for wraparound services such as housing, food, etc., do you generally receive pushback, or do funders generally understand the need to address these basic social determinants of health that are often overlooked?
That's loaded. Funders, I don't think, well, I think it depends on the funding stream, number one. They're typically not going to be people with lived experience, but that doesn't mean that a lot of my colleagues are even coming up and becoming funders, right? So you just never know with this culture shift that I mentioned, but I don't think it's lost on them regarding the need. I think what is often overlooked and really unfortunate is how flexible it needs to be because of the barriers that are in place, right? And so a funder can't literally go to every county and look at every policy and work to, find flexibility around it. but it is, I think, more up to different state localities to enable provisions that can make a lot of this work. So funders mostly have to be flexible. I think that if I'm really understanding your question, the most success that I have had with funding streams, and the reason why we were even able to launch this project, was because of opioid settlements and the flexibility that came with that. Foundations, flexible. I don't get any pushback regarding a lot of the things that, they know I need to use it for, that meet the, social determinants of health and really support an individual's well-being. State and federal sources are much different. There's a lot of red tape. And again, I think it also comes down to counties and procurement offices and people, really calling in, peer advisory boards to really help direct the funder to meet the need and how to do that, as far as, what kind of parameters you're setting in an RFA or an OFO.
All right, we have another question. Someone's asked if you could define SSP.
It's Certain Service Program.
Thank you. Are there any other questions? We have maybe a couple more minutes for some questions. And if anybody wants to verbally say their question, you can feel free to just use the raise hand feature. And I'll just call on you and you can unmute and ask your question. Beth, you can go ahead.
Yes, first of all, thank you so much, Lawrence, for that presentation. And this is actually just a comment because I put it in the chat, but I realized that the chat will disappear, is that if you want a really thorough account of this through line that Lauren described between slavery, the war on drugs, mass incarceration, structural racism, the documentary 13th is excellent, and you can watch it for free on Netflix. I put the link in the chat, or on YouTube. So
yeah. And I appreciate the comments in the chat. I really want to echo that for the lived experience that I do have. A lot of this is not my story. I am working to do my part. I think everyone on this today and beyond can do more. I think a lot of this has to do with policy change and getting uncomfortable. And that's okay. It's okay to wade through a little bit of rough water to get some meaningful change. And thank you for having me. I really appreciate this opportunity.
Thank you for coming today. We really appreciate it. If there are no other questions at this time, we'll go ahead and wrap up. But Lauren, thank you again. And as I mentioned, I will be sending a follow-up email that'll have the slides, Lauren's contact information for anybody who wants to follow up directly with her. And it'll have more information about our next webinar. And so thank you so much to those of you who joined us today and who hung on for a little bit longer. We really appreciate it. And we hope to see you next month on the 13th. All right. Everybody have a good rest of your day.